Chapter 15. Acute respiratory failure. Acute respiratory failure is defined as an inability of the respiratory system to provide oxygenation or remove carbon dioxide from the body. ARF is classified as oxygenation failure resulting in hypoxia without a rise in the carbon dioxide levels, or a ventilation failure resulting in hypercapnia and hypoxemia. This oxygenation failure, also known as type 1, is characterized by a PaO2 of less than 60 millimeters of mercury, with normal to decreased levels of carbon dioxide. On the other hand, ventilation failure, also known as type 2, is characterized by a PaCO2 greater than 45 millimeters, as well as altered gas exchange, with failure of oxygenation, ventilation, or both. When differentiating the assessment cues that would indicate acute respiratory failure, for oxygenation, you'd be looking at things like tachypnea, anxiety, or low oxygenation on pulse oximetry. On the other hand, ventilation would be indicated by a work of breathing, as well as the tachypnea, increased CO2, and an oxygenation that may not initially be low. Acute respiratory failure is defined as that inability of the respiratory system to provide the oxygenation and/or removal of carbon dioxide from the body. Oxygenation failure occurs when the PaO2 cannot be adequately maintained and is most commonly occurring type of ARF. There's 5 generally accepted mechanisms that reduce the PaO2 and create a state of hypoxemia. They are 1. Hypoventilation, 2. Intrapulmonary shunting, 3. Ventilation perfusion mismatching, 4. Diffusion defects, and 5. A decreased barometric pressure. The oxygen decrease can result from a variety of factors. Non-pulmonary conditions such as decreased cardiac output and low hemoglobin level may also result in tissue hypoxia. There are many factors that can result in hypoventilation and the decreased oxygenation and ventilation. The factors that can lead to hypoventilation include a drug overdose that causes central nervous system depression, neurological disorders that can cause a decrease in the rate and/or depth of respirations, and abdominal or thoracic surgery leading to shallow breathing patterns secondary to pain on inspiration. A pathological shunt exists when areas of the lung that are inadequately ventilated are adequately perfused. The blood, therefore, is shunted past the lung and returns unoxygenated to the left side of the heart. Primary causes of shunting leading to hypoxemia include atelectasis, pneumonia, or pulmonary edema. For clinical judgment, why does the administration of higher levels of oxygen not help a shunt disorder? As the shunt worsens, the PaO2 continues to decrease. This cause of hypoxemia cannot be effectively treated by solely increasing the fraction of expired O2. Because the increased oxygen is unable to reach the alveoli, treatment is directed towards opening the alveoli and improving that ventilation. A ventilation or perfusion mismatch occurs if either ventilation or perfusion is decreased. If the ventilation exceeds blood flow, then the VQ ratio is greater than 1. And if the ventilation is less than the blood flow, the VQ ratio is less than 1. Common causes are things like pneumonia, pulmonary edema, or even a pulmonary embolism. Diffusion is the movement of gas from an area of high concentration to an area of lower concentration. In the lungs, O2 and CO2 move between the alveoli and the blood by diffusing across the alveolar capillary membrane. The diffusion defects impair gas exchange, and poor oxygen exchange is the first parameter to alter hypoxemia. For CO2, this is more readily diffusible, so hypercapnia is a late sign of a diffusion defect. In case of low cardiac output, there are many conditions that can decrease the cardiac output, which will in turn impair oxygenation. If cardiac output decreases, less oxygenated blood is delivered. To maintain normal aerobic metabolism in low cardiac output states, the tissues must extract increasing amounts of oxygen from the blood. As you know, hemoglobin is necessary for the transport of oxygen. In the case of oxygen saturation, this refers to the percentage of the oxygen binding sites on each hemoglobin molecule that are filled. And the normal value is approximately 96 to 100%. Unfortunately, many critically ill patients have low hemoglobin levels secondary to a variety of factors. The final step in oxygenation is the use of oxygen at the tissue level. If tissues are hypoxic, anaerobic metabolism and lactic acidosis result. The effects of tissue hypoxia vary with the severity of the hypoxia, but may result in cellular death and even subsequent organ failure. Quick quiz. Which condition would the nurse suspect respiratory failure secondary to hypoventilation? Would that be A, anxiety, B, a neuromuscular disease, C, pulmonary embolism, or D, a ventilation at a rate of 20 breaths per minute? And that answer is going to be B, a neuromuscular disease. Hypoventilation is the cause of respiratory failure that occurs in patients with CNS abnormalities. Neuromuscular disorders, overdoses such as alcohol, benzodiazepines, or opioids, as well as chest wall abnormalities. In the case of clinical judgment, how does hemoglobin affect oxygenation? And again, that low cardiac output. Adequate tissue oxygenation depends on a balance between O2 supply and demand. And the mechanism for delivering that oxygen to the tissues is cardiac output. A normal cardiac output results in the delivery of 600 to 1,000 milliliters a minute of oxygen, which generally exceeds the normal amount of oxygen O2 needed by the tissues. If the cardiac output decreases, the less oxygenated blood is delivered. To maintain normal aerobic metabolism in low cardiac output states, the tissue must extract increasing amounts of oxygen from the blood. When this increase in extraction can no longer compensate for the decreased cardiac output, the cells convert to anaerobic metabolism. This results in the production of lactic acid, which depresses the function of the myocardium and further lowers cardiac output. On the other hand, low hemoglobin levels, between 96 and 100% of the body's O2, is transported to the tissues, bound to hemoglobin. These O2 binding sites are filled, and each gram of hemoglobin can carry 1.34 milliliters of O2. Arterial oxygen saturations, SaO2, also refers to the O2 percentage of the binding sites on each hemoglobin molecule. Hemoglobin level is lower than normal. The oxygen supply to the tissue may be impaired, and tissue hypoxia can occur. An alteration in hemoglobin function, such as carbon monoxide poisoning or sickle cell disease, can also decrease the effectiveness in oxygen delivery to the tissues. For a failure of ventilation, this could result in hypercapnia, such as when the ventilation is impaired, the PaCO2 increases. In the case of hypoventilation, this is going to be one common cause, and the ventilation perfusion mismatch is another cause. The goals of treating patients with acute respiratory failure include maintaining a patent airway, optimizing O2 delivery, and minimizing O2 demand, treating the cause of acute respiratory failure, and further preventing complications. A comprehensive assessment is helpful in determining the etiology of respiratory failure, as well as a response to treatment. Neurological changes are the earliest sign of respiratory failure. Because of age-related decreases in chemoreceptor and central nervous system function, older adults have a lower ventilatory response to hypoxia and hypercapnia. Many interventions are used to treat respiratory failure. Of the most importance is to optimize oxygen delivery and minimize oxygen demand. There are several nursing diagnoses to apply to the patient with respiratory failure, such as impaired ventilation, ineffective airway clearance, infection, anxiety, impaired skin integrity, or ineffective coping. Other things to include in the plan of care would be ineffective breathing patterns, impaired gas exchange, fluid volume excess, and even altered nutrition. The medical management would focus on oxygen, bronchodilators, corticosteroids, sedation, transfusions, therapeutic paralysis, nutritional support, and careful hemodynamic monitoring. Quick quiz. Which intervention should the nurse use to maximize airway clearance? Would that be A, administer supplemental oxygen, B, elevate the head of the bed, C, provide oral care every 4 hours, or D, reposition the patient every 2 hours? And that answer is going to be D, reposition the patient every 2 hours, as this will be an effective strategy to help mobilize the secretions. Let's talk about ARDS, acute respiratory distress syndrome. The definition of ARDS has expanded since originally identified in 1967. The criteria includes 1, the acute onset within 1 week of a clinical injury, B, a bilateral pulmonary opacity is not explained by other conditions. Or 3, an altered PaO2 ratio. The diagnostic criteria are universally applied, with the PaO2 and FiO2 ratio is a very important assessment. This severity is determined by the PaO2 and FiO2 ratio, as well as the PEEP or CPAP requirements of over 5 centimeters. In the case of mild ARDS, there would be 201 to 300 millimeters of mercury. And in the case of moderate, would be 101 to 200. And finally, severe, anything over 100 millimeters. For our case study, a 31-year-old female is admitted to the critical care unit with respiratory distress after getting the flu. Her condition worsens, with an SpO2 being 85% on Venturi mask at 50%, and ABGs showing a PaO2 of 50 millimeters. Her chest x-ray is showing infiltrates. Mrs. J is placed on non-invasive positive pressure ventilation. Why is this decision made? Because she is in respiratory failure. A trial of this intervention may be done to avoid the need for intubation or even mechanical ventilation. Within 2 hours of MPPV, Mrs. J is getting worse. Her SpO2 remains at 85%, and the oxygen via MPPV was 80%. Her chest x-rays also show bilateral whiteout. And in this case, what treatment is indicated? We're going to be moving forward and considering more drastic interventions like intubation or mechanical ventilation that are urgently needed. If the PaO2 is 60 millimeters and the FiO2 is 0.6, the PaO2 FiO2 ratio, would that be A, 100, B, 1000, C, 360, or D, 3600? And that answer is going to be 100, with the math being 60 divided by 0.6 equaling 100, and this patient would be in ARDS. The pathophysiology of ARDS results in non-cardiogenic pulmonary edema. Most common risk factors for this being processes associated like sepsis, pneumonia, shock, or even aspiration of gastric contents. Other considerations would be things like microatelectasis, decreased compliance or stiff lungs, decreased surfactant or damage to the type 2 pneumocytes, or things we've already discussed like impaired gas exchange or that ventilation perfusion mismatch. What patients would you identify as having a high risk of developing ARDS? And these would be patients that should be hyperventilated early in the course of the disease as an attempt to increase oxygen delivery. Early cases will have respiratory alkalosis. And next, what is a possible etiology of ARDS for the patient in the discussed case study? And we'll be looking at history indicating flu-like symptoms. She likely developed these symptoms as from an acute viral infection. ARDS has many symptoms and deterioration occurs. There's also a need to monitor ABGs and complete serial chest x-rays. Once ARDS is diagnosed, an important assessment data are used to guide the treatment, including hemodynamic measurements, ABGs, mixed venous blood gases, breath sounds, CT scans, complete blood cell counts with differential, as well as blood and sputum cultures. The treatment of GARDS is going to be guided by primarily treating the underlying cause of the condition and focusing on oxygenation and ventilation. The patient is placed on volume assist or control ventilation at a rate of 16 breaths a minute. What is the rationale for these settings? In this case, the patient needs adequate oxygenation and ventilation, and this mode will prevent ventilation since she is severely hypoxemic. A high level of oxygen is going to be required, and the PEEP is going to be used to maximize the oxygenation. Comfort is also an important intervention in managing the patient with ARDS. Prone positioning may be required, and research findings are mixed regarding proning, so each patient must be assessed for response. The patient's condition does not improve, and the SpO2 is 85%, and the FiO2 is increased to 0.9 to maintain this. And then finally, a decision is going to be made to increase the PEEP to 20 centimeters of water. About 10 minutes after the PEEP is increased, the patient's blood pressure drops to 80 over 50, and the breath sounds are equal bilaterally. Explain the rationale for why this blood pressure dropped. And what is the significance of the bilateral breath sounds? There's going to be several complications that occur from high levels of PEEP, including pneumothorax or tension pneumothorax. The bilateral breath sounds would likely rule out a pneumothorax, and the high levels PEEP decreases venous return and can reduce cardiac output. Optimum PEEP that maximizes the oxygenation without decreasing the cardiac output must be determined and measured and implemented carefully. Nutrition and fluid management must also be provided in the patient with ARDS. Due to the critical nature of the patient, psychosocial support for the family is another important intervention. The patient may receive non-traditional modes of ventilation, oscillatory ventilation, or proning. All of these can increase family stress. ARDS must be alert for complications, long as multiple organ dysfunction syndrome, renal failure, disseminated intravascular coagulation, and long-term pulmonary effects associated with high oxygen and other therapies. The patient's condition continues to worsen, and a decision is made to try the oscillator ventilator. Why is this made? Because Mrs. J was unable to be oxygenated with high levels of FiO2 and PEEP. A new ventilator strategy is going to be needed. The oscillator may successfully recruit alveoli in cases of severe ARDS. Despite the oscillator, the patient's condition worsens. The physician discusses her grave condition with her husband. They mutually agree to make her a do not resuscitate DNR. The husband and her parents are encouraged to spend time with her in the room and are supported by the staff. Unfortunately, the patient dies about 4 hours after the DNR decision. When looking at the psychosocial implications of this case for both the family, nurse, and the multiple professional team, it's going to be very dependent on many aspects of the patient. Now, what was their age? Was there a young spouse? Do the patients not expect their child to die? Has this been a condition that has been a long time coming and they've had an opportunity to prepare for? The response to both the family as well as the healthcare team is going to vary wildly depending on each unique patient situation. Acute respiratory failure and COPD. Patients with COPD can have acute respiratory failure in addition to the chronic respiratory failure. And this would be due to things like secretions and bronchoconstriction. For our assessment, we're going to be looking at things like anxiety, wheezing, chest tightness, tachypnea, tachycardia, fatigue, confusion, or even fever and sleeping difficulties. In the case of wheezing, this is going to indicate a narrowing of the airways. And retraction of the intercostal muscles may occur with inspiration or exhalation that is prolonged through pursed lips. The patient is generally more comfortable in the upright position, and tachycardia and hypotension may result from the reduced cardiac output. To correct hypoxemia, we're going to use cautious administration of O2, and it should be administered to achieve a SaO2 of 88 to 92%. A Venturi mask will also deliver more precise oxygen concentrations. For pharmacologic therapy, we'll be looking at commonly administered bronchodilator agents, such as short-acting beta agonists, with adverse effects including tachycardia, dysrhythmias, tremors, hypokalemia, anxiety, bronchospasm, and dyspnea, though I believe we have talked about albuterol a lot in the previous semester. We may also be looking at things like long-acting beta agonists that are effective in controlling stable chronic COPD, such as things like prednisone at 40 milligrams per day for 5 days, being a often recommended regimen. Common adverse effects of steroid therapy do include things like hyperglycemia and an increased risk of infection, however. MPPV is indicated for dyspnea with respiratory muscle fatigue or respiratory acidosis, and assists the patient's respiratory efforts by delivering positive airway pressure through a nasal, oronasal, or full face mask. Intubation and invasive mechanical ventilation are indicated in those patients who fail trials of MPPV or who have persistent or worsening hypoxemia, respiratory arrest, cardiac arrest even, or even possibly decreased level of consciousness. For the episodic airflow obstruction that results because these irritants cause bronchoconstriction, airway edema, mucus plugging, and airway remodeling. Asthma is often well managed. but an acute exacerbation can result in admission to the critical care unit for treatment. A common cause of exacerbation is noncompliance with the medications. Causes like the bronchodilators are no longer working, or just noncompliance, the patient stopped taking their medication. Hyperventilation with air trapping can result in respiratory acidosis, or even severe hypoxemia. Aggressive treatment is needed to prevent the need for intubation. Oxygen, steroids, and bronchodilators are going to be essential treatments. Teach the patient to implement environmental controls to prevent symptoms. Also, to help understand the differences between medications that relieve or control the symptoms, and to properly use the inhaled devices, as well as monitoring for the level of asthma control. Help to think about the nursing interventions used to alleviate anxiety in a patient with status asthmaticus. Also, think about the optimal position for in which to place the patient to help improve and facilitate gas exchange in this condition. You also want to help keep the patient in a position that maximizes respiration. And that's often going to be a semi-Fowler position. You also want to reinforce adherence to the prescribed medical therapy and monitor for early signs and symptoms. When it comes to pneumonia, there's going to be several different types: community acquired, healthcare associated, hospital acquired, or ventilator associated. There's also going to be a greatly increased risk in people like the elderly, alcoholics, smokers, chronic diseases, head injury, or immunosuppression. In pneumonia, the organisms overwhelm the normal protective respiratory defense mechanisms. Aspiration is another common cause of pneumonia and can result in impaired mucus clearance. This inflammatory response leads to a ventilation perfusion mismatch, resulting in dyspnea, hypoxemia, fever, and leukocytosis. When dealing with prevention, look at things like the influenza vaccine. All persons over 6 months it is recommended for, and especially for people at high risk of complications from the flu, people in contact with those at high risk, and especially healthcare providers. At the age of 65, the pneumococcal vaccine is also recommended to prevent streptococcal or pneumococcus. Common signs and symptoms of pneumonia include things like fever, cough, purulent sputum, hemoptysis, dyspnea or tachypnea, chest pain, and even adventitious breath sounds. Which arterial blood gas alteration in pneumonia are expected? That be A, hypoxemia and respiratory alkalosis, B, normal oxygen and respiratory acidosis, C, hypoxemia and metabolic acidosis, or D, normal values. And that answer is going to be A, hypoxemia and respiratory alkalosis. In this case, arterial blood gases are going to demonstrate the hypoxemia as well as hypocapnia, respiratory alkalosis. Ventilator-associated pneumonia is often associated with intubation and mechanical ventilation, and it can also be difficult to diagnose accurately. Alternative assessments include clinical pulmonary infection scores and an assessment of ventilator-associated events with the latest trends in monitoring. Monitor many different CDC website for updates. The National Healthcare Safety Network also now includes ventilator-associated pneumonia as one of several problems of oxygenation. And there is going to be a ventilator-associated pneumonia bundle of care that can help prevent this condition. And it's going to be everything from maintaining the head of the bed 30 to 45 degrees, minimize sedation, using a protocol to guide a daily spontaneous breathing trial, adequate daily oral care with toothbrushing, maintaining the improved physical conditioning, providing early enteral nutrition, and avoiding intubation wherever possible. To prevent VAP, what is the recommended elevation for the head of the bed? That be A, 15 degrees, B, 20 degrees, C, 30 degrees, or D, 45 degrees. And that answer here is going to be C, 30 degrees. It's recommended that the head of the bed be elevated 30 to 45 degrees to prevent the risk for aspiration of gastric contents. In the case of Virchow's triad, we're going to be looking at things like venous stasis, altered coagulability, and damage to the vessel walls. In the case of pulmonary embolus, this is going to be a very real concern, especially for these patients that are not up and moving and are going to be a greatly increased risk of throwing a clot. When assessing for a PE, we're going to be looking at things like symptoms of a DVT, chest pain, dyspnea, tachycardia and tachypnea, or even hemotysis, crackles, wheezes, and hypoxemia. There's going to be many different diagnostic tests, including the classical signs and symptoms, a D-dimer assay, duplex therapy, high resolution multi detector CTs, or pulmonary angiogram. Medications would include things like heparin with low molecular weight heparin, mechanical for like sequential compression devices, foot pumps, compression stockings, and frequent position changes. Also, keep in mind it's a very common NCLEX question to avoid putting pillows under the knees. When treating a PE, we're going to be looking at ABCs, oxygen, thrombolytics, heparin, as well as surgical procedures in very severe cases. Cystic fibrosis, a condition you may have heard of. This is going to be a genetic disorder resulting in a mutation in the chloride transport. And basically, this condition is characterized by thick, heavy, sticky mucus that affects many different parts of the body. We primarily think of it as a respiratory condition because that is often what unfortunately kills the patient. It also affects the lungs, but as well as the pancreas, liver, salivary gland. And unfortunately, that thick, heavy mucus, it is very hard for the patient to move. So they need a lot of excess fluids. We want to do everything we can to keep that mucus as thin as possible. Cystic fibrosis is considered to be a disease of childhood, and though fortunately improvements of care have prolonged that life expectancy greatly. A cornerstone of care for a patient with cystic fibrosis include things like antibiotic therapy, airway clearance, nutritional support, and ventilatory support. In genetics, it is a chronic disease of exocrine function. There's also autosomal recessive patterns. When both parents are carriers of the genetic variation, there's a 25% chance of inheriting cystic fibrosis, unfortunately. When considering a lung transplant, some of the criteria include a 50% risk of death from lung disease within 2 years, or an over 80% likelihood of 5-year post transplant survival. And wrapping up with key points. Prompt and thorough respiratory assessment is going to be essential in early detection and treatment of acute respiratory failure. We also want to work to maintain airway while optimizing oxygen delivery, minimizing demand, and identifying and treating the cause. We also want to focus our treatment of managing ARDS on the mechanical ventilation with low tidal volume. Also, COPD exacerbations that include providing supplemental oxygen, or even most importantly, a silent chest in a patient with asthma exacerbation. That's going to be an ominous sign because we are getting no air movement. When focusing on the prevention of pneumonia, we also want to be focusing on the prevention of ventilator assisted pneumonia, assessing for any risks and implement interventions to reduce the dangers of a PE. And in the case of adult patients with cystic fibrosis, they're going to require an individualized plan of care, focusing on everything from airway, nutrition, to infection prevention strategies. But anyway, that's all we got for this chapter. I'll see you in the next slides.